my charge is to talk about the volar lunate facet fragment. And, the goals for this are basically want to try and understand the unique anatomy of this lunate facet with the help of radiographic evaluation and fracture pattern assessment, and then decide which surgical approach suits our particular case and evaluate various fixation strategies. And we'll do this with the help of 5 cases, each of which has an attached reference which highlights what I'm talking about, and each of which will have 1 or 2 important points. Now, if we think that we've gotten really cognizant of this problem in the last 15 or 20 years, think again, because Terry Axelrod wrote about this particular problem nearly 32 years ago. So what is so unique about the lunate facet? Well, it is not located at a level that you would want it to be to fix it with a volar monoblock plate, in that it extends volarly, distally, and ulnarly. And as shown in this picture from Amit Gupta's dissections, it bears the attachment of the radiolunate ligament, which goes all around the equator, if you want to call it that, as seen highlighted by this purple circle. Therefore, if you were to not pay attention to it, and you think that the fracture is represented by this purple line, then think about it. Right attached to that fragment is your short radiolunate ligament. And if this fragment were to displace as shown by this blue arrow, then not only does the fragment go that way, but it takes the entire carpus with it due to the attachment of the short radiolunate ligament. So therefore, before we start treating this, we should recognize it. And how do we recognize it? Well, in non-CT available situations, the best way to do is what Rob Medoff told us, is to measure the teardrop angle. The teardrop angle is basically a surrogate for the volar inclination of the volar lunate facet. And normally it is about 65 to 70 degrees and is measured as shown in this diagram here. If the teardrop angle increases, it usually represents a volar marginal shear, either an isolated volar lunate facet fragment or a volar Barton fragment. Conversely, if it reduces, it usually represents central impaction. Now, plain radiographs are good, but if a CT scan is available, I'm going to go out on a limb here, then a CT scan must be done so that you can assess the fragment geometry carefully, because only then can you analyze the fragment and the fracture patterns. Over the last 30 years, in my assessment, the fracture patterns usually follow these 3 patterns almost reproducibly and consistently. The first pattern is what I call the boomerang pattern, which is seen on the left side, and it is usually seen in isolated fractures or in volar Barton fractures, as shown here. The second pattern is what I call the sliver, which is commonly seen in radiocarpal fracture dislocations. And finally, the third pattern is the column, which is seen in isolated fractures as well as in complex distal radius fractures. I won't belabor the point by reading this, but I'm going to leave this for about 5 to 7 seconds. These are the tools I keep handy in my operating room whenever I'm dealing with fracture of the distal radius where I'm concerned that a lunate facet fragment may be present. So let's start off with case number 1. Now, when you're dealing with an isolated lunate facet fracture, you have to have adequate knowledge of the various tools of the trade that you have to have available. This paper highlights those tools. So here's a 62-year-old female registered nurse who fell from standing height. And you can see from the x-rays on the left that she already has pre-existing radiocarpal arthrosis. Her teardrop angle, as seen from the x-ray in the middle, is clearly increased, and a CT scan shows that the entire volar lunate facet has come off. So these fractures, when they're isolated in this fashion, I usually approach with this extensile approach, the extensile carpal tunnel approach, and I take the plane between the median nerve and flexus on the radial side and the ulnar neurovascular bundle on the ulnar side. Now, here's the tip. If you flex the wrist and put a large bump behind it, retracting the median nerve is much less tortuous to the median nerve itself, which is shown here by the red arrow. How do you identify the fragment? Because when you elevate the pronator quadratus, you can barely see anything. So I usually run a FREER along the ulnar aspect of the distal radial shaft until I feel that uneven step of the radial cortical defect. I then exploit that defect elevate the fragment and push it distally. And it leaves me with this boomerang-shaped defect, which I then graft, and I fix it with a headed screw, which is cannulated, put a guide wire in, and you can see that it looks pretty good. I then push the guide wire out the other side so I can grasp it with a forceps or a snap so that it doesn't come out when I'm drilling. And then it's just a matter of putting a screw in over it. I use a screw with a washer because it behaves like a one-hole plate. Is that adequate? In some circumstances, it is. But this lady had come to me a little later, and she had to be grafted, as you can see from these pictures here. I had to use graft once I elevated her back. And I therefore felt that the stresses on that one screw would be too much for it to bear. Therefore, I used a buttress plate along with the screw and gave an additional layer of security. And here she is at 9-year follow-up, doing reasonably well with no pain. Case 2 highlights the fact that we have to go away from the concept that volar Barton fractures are single fragmentary. They are multi-fragmentary in my book, unless proven otherwise, and this paper highlights that concept. So here we are, a 30-year-old male who came off a motorcycle at very high speed, and as you can see, he's got a volar marginal shearing fracture, if you want to call it a Barton's. And as you can see from the CT scans, the red arrow and the yellow arrow are pointing to the lunate facet, and you can clearly see that this is multi-fragmentary. So the teaching I do with my residents is a volar Barton fracture, unless proven otherwise, will always have a separate lunate facet fragment, which you have to be on the lookout for. Now, in the days that I fixed this, I was ready to fix it with a standard FCR approach, and that's what I tried to do, quickly realizing that my access to the lunate facet fragment was inadequate. So point number 2 for this particular case is that you don't have to panic, don't have to make a separate incision, merely take your dissection subcutaneously all the way across to the median nerve, and then you retract it so you can approach the lunate facet fragment from the ulnar side. Why do I need to do this? Because the trajectory of fixing this with a screw requires an angulation of your hand so much that you can't do it from the FCR approach, and you have to bring your approach over to the ulnar side. And then I fixed the fragment with the screw and added my monoblock plate to fix the rest of the fracture. And here he is at about 6 months. This case highlights how to manage radiocarpal fracture dislocations, which usually consist of very, very small fragments. Here's someone who was involved in an MVA. And if you look at these x-rays, you don't get a sense that the lunate facet is involved at all until you get a CT scan, thereby highlighting my point that getting a CT scan is critical in these fractures, if at all possible. So you look at these fragments and you can see a dorsal radial fragment, you can see a radial styloid fragment, as well as a lunate facet fragment. Now we know that this fracture geometry is predictable and consistent in radiocarpal fracture dislocations type 2. So when you have these small fragments, you cannot really fix them with a plate. And therefore I say small fragments means small devices. So I chose to fix each fragment on its merits with a screw, either cannulated or not, and I fixed the lunate facet fragment with a suture anchor. So that's another trick to remember. And here she is at about 1 year. How about a delayed diagnosis? This paper highlights the features of delayed diagnosis and how to approach decision-making when taking care of a delayed diagnosis. Here's a male who underwent multiple debridements for PVNS affecting his wrist. And the surgeon who took care of him had done all of these debridements with using an extensile carpal tunnel release approach. So I had no choice but to utilize that. He was told that he had a wrist sprain until he came to see me at 3.5 weeks because his wrist was still hurting, and that's what he looked like. Now you look at his CT scan and you realize that he has a sliver pattern of avulsion or a displacement of his lunate facet, but this sliver actually extends halfway across into the scaphoid fossa. So for me, this was too large to be fixed either with an L plate or with a screw, and besides, he had come to me almost 3.5 weeks down the line. So I chose to do something a little different. The yellow arrow points to his PVNS spouting out through the volar wrist capsule. I chose to use a T plate, and if the surgical trick to remember here is that if you use a 2.4 millimeter T plate, then a 3.0 millimeter cannulated headed screw actually fits through this plate. So I chose to put the guide wire through the plate, buttressed it before, and then fixed it. As you can see, grabbed the fragment, guide wire is coming out the dorsal side, and put my cannulated screw over it to add an additional layer of security because this was an older fracture. And here he is at about 1.5 years, doing reasonably well. His radius scaphoid articulation is arthritic, but it was before he came to see me. Finally, an intraoperative diagnosis needs to be addressed, especially in the older person who is osteoporotic and whose requirements for fixation may be entirely different from those of a younger person. Here's a lady who fell out of an olive tree, and when she comes to see me, you can see that her teardrop angle is actually reduced, thereby suggesting some degree of central impaction. So I was reasonably confident that I could address this with a volar monoblock plate and went about doing that. But here's the lesson I learned, that intraoperatively, you must always look at the lunate facet, because there was something not quite right, as shown by these red arrows. You can see a separate shadow, and that was the displaced volar lunate facet. So this was a relatively easy fix. I used a one-hole plate with a cannulated screw with a washer and restoring that important fragment. And there she is at about 1 year. So these are the common fixation techniques, but can you use alternative techniques? Now, whenever you're dealing with these injuries, you have to always be prepared to look next door. What do I mean by that? Here is a case which was reduced of a radiocarpal fracture dislocation, and you can see that the post-reduction X-rays actually highlight a concomitant scaphoid fracture. So whenever you see these injuries, especially if you're going to get a CT, always scan the entire CT to look for carpal injuries. So in this case, you look at this fragment, it is quite small. And I was quite confident that I would not be able to fix it with the traditional fixation techniques. So I chose to do what Jesse had described many years ago. I used a wire suture, and I passed it around a 2.7 millimeter screw, which I used as a post, something that I learned from our sports medicine colleagues. So that's a wire suture, which pulled it right back into place, giving it an excellent restoration of the volar lunate facet. So what are the take-home messages? The volar lunate facet extends distally, volarly, and unlarly. You have to maintain a very high index of suspicion at all times to look for it and be prepared to fix it. The fracture geometry, in my opinion, is largely predictable, and small fragments require small implants. So I'm going to stop there, but the last two slides will help learners get some references that I'm talking about, and they are provided here for your future reference. Thanks very much.